So at this point in time, we have 3 CD19 CAR T-cell therapies that are approved in the third-line setting, namely liso-cel, axi-cel, and tis-cel. And we have 2 CD19 CAR T-cell therapies approved in patients with second-line large B-cell lymphoma. In the transplant-eligible ones, we have axi-cel and liso-cel, and in the transplant-ineligible second-line setting, we have liso-cel. However, I think the new kid on the block has been the CD20 bispecific T-cell engagers, and these products basically activate the innate T-cell and cause death of the tumor cell. So clearly there is an advantage there because these are off-the-shelf products, and at this point in time there are 2 CD20 bites that have been approved in the third-line setting for relapsed refractory large B-cell lymphoma, namely glofitamab, which is time-limited for 12 cycles but given intravenous. On the other hand, there is epcoritamab that's given until progression, but it's subcute. In the pivotal studies that compared the 2 molecules, they were quite similar. There was about 1/3 of the patient population that had received CD19 CARs in the past, and prior CAR Ts did not seem to impact the efficacy of CD20 bites. So which is heartening to see that we have so many agents now that we have at our disposal for patients who have relapsed with large B-cell lymphoma in the third-line setting. The big question is, how do we choose? How do we sequence? I do believe that majority of large B-cell lymphomas relapse happen, which are high risk. So majority end up getting CD19 CAR Ts based on the label because there is a cure that has been established in the third line and in the second line. So obviously the intuitive next sequence when patients fail CD19 CARs is bispecific T-cell engagers. We know they work. But I think the real question is in the third line space, if you have to make a choice between CD19 CARs and bispecifics, which ones would you choose? And I think CD19s for sure. With regards to CAR T-cell therapy, logistically it's more cumbersome, it's not off the shelf, but it's one and done treatment. It does have a cure rate that has been established. 40% of patients can be cured who would have otherwise succumbed to their disease in the third line space. We don't have that kind of data with CD20 bites yet. So far we have an 18-month follow-up. At EHA we have an EPCO follow-up in the large B-cell lymphoma category, and it's hard for me to see a plateau yet, which means I don't believe that there is a cure that is beginning to emerge. But at the same time, there are other issues. For example, antigen expression is something that has known to impact CD20 bite and its efficacy. So patients who have CD20 negativity, they don't do as well with CD20 bites as patients who have CD20 positivity. Patients with CNS involvement were excluded for majority of the CD20 bites trials. So with those patients who have active CNS disease, we know CARs work. We don't have that kind of a data which is robust and prospective with CD20 bites. So as a result of all of these variables, which would be the fact that there is a cure rate with CD19 CARs, there is a one and done therapy with CD19 CARs, there is established CNS efficacy, and the antigen expression doesn't matter. I think in terms of sequencing, I do believe CD19 CARs over CD20 bites. But at the same time, not every center can do CD19 CARs. So I do believe that there is going to be a surge in terms of an uptick in the community where maybe CD20 bites are going to be chosen. At EHA, there is going to be the StarGlow study that is being presented by Dr. Jeremy Abramson at the plenary session that showed an overall survival benefit in the second line setting with GemOx plus glofitamab. So I'm really eagerly awaiting that presentation, because that is certainly going to ramp up things very differently, which means if people get second line bites, then what remains for them in the third line setting? There's a theoretical concern about T-cell exhaustion after CD20 bites, but I think the space is evolving as we all speak. Clinical trials are going to be the key to figuring out how best to manage our patients with large B-cell lymphoma.